Okay.
And
Um,
then
but
what do you, this is going to be a weird question, but what do you typically call do you call your people clients, patients, like when you're working
cli-
with,
clients, we don't have patients. And I mean, nurses and midwives will have patients, but birth doulas, childbirth educators have clients. Yeah, thank
clients?
you
Okay.
for asking that. Mhm.
Okay.
Yeah. And
Well,
then
you,
the other thing I want to make sure that I am prepared to do is to drop in you sent handouts. Excuse me. Um, you sent 5 handouts. Do you want all of those dropped into the chat at some point
um,
or sent later?
I think most of them can just be sent later, honestly. I mean, you
Okay.
can do both if you want, it doesn't matter. But I would say if you send them in the chat, I can let you know like when to go ahead and start sending those because it's towards the end of the presentation. It's really just like when I'm starting to talk about how to actually make referrals and how to find referrals in their location, so that they can kind of make those personalized, um, some tools to help with that. So
Yeah. Like I'm
I could
thinking like
let
when you do the Edinburgh scale, that
you,
might
yeah,
be helpful to when you're talking about that. I'll just drop that in.
that's perfect.
Um, yeah. Do we have that twice in there? Or is that? No. Okay. And then the same with the perinatal anxiety scale. I'm really excited about your talk. It's going to be good.
Oh, I hope so.
It's,
I
it's
hope it's
a,
helpful.
it will
I
be. It
I
will be for
I
sure.
tried to keep it like general in some ways, and then we get more specific towards the end, but I hope I mean, some stuff I think people will already know and some people will be familiar with, and so I'm just hoping that
Mhm.
people can pull little, whatever they can from it.
Yeah, I think so. And I think, like from the doula point of view, or the childbirth educator, but especially the doula point of view, whether you're a birth or postpartum doula, things that will help us know what we should be looking for when we're going in that postpartum period to see our client or in the prenatal period,
Yep.
what are the red flags that we should be looking for in our work with our clients so that we can educate them
Yeah.
and provide some guidance for them. So I see it, to me, it looks like you're going to be covering all that. So that's fabulous.
Yes, I
Really,
hope
really
so.
good.
And then if I
Yeah.
don't, I mean, I'm happy I love doing this type of stuff. This feels like something fun that's switches up. I used to teach a lot and do different presentations, so I don't get to do this as much anymore. So I'm glad you asked. I
Yeah.
really appreciate it.
Well, I appreciate you doing it. It's
Of
well,
course.
listen, sometimes always feel a little bit like we can't pay you, but but it's kind
Oh,
of, we just feel like, gosh, if we can benefit
oh,
our
exactly.
clients, if we can benefit the workers, that's going to be really important. So yeah.
Absolutely. The
How
more
are you?
people that, what's that?
I was gonna say, how are your babies? Speaking of babies.
They're good. They're good. They're, Archie and Annie have birthdays this spring, so gonna be 6 and 4, and then Augie's already 18 months, which feels impossible. Um,
Yeah, yeah.
but they're good. We were
Wow.
like really, really sick all winter, like got one thing after the other, and then finally
Mhm.
now I feel like we're in the clear again, and that's been
Mhm.
nice. So,
Wow.
but loving it. I really love summers with the kids at this age, like just pool time and going to splash pads, and so I'm looking forward.
Yeah, that's cool.
How are you doing? Where is your office
I'm
located
well.
now?
Well, I mean, right now I'm actually down in Florida.
Okay.
Um, but I had to bring my office back home because of my mother-in-law, just to be able to really care for her in a better way. And to kind of give her a little more like stimulation throughout the day, in and out. So I have an office space that's over our carport, and it's actually really lovely. But I so enjoyed being at the nest.
Yeah.
Um, but it just didn't work out well because I felt like I was spending more time driving back and forth instead of just being able to like run down quickly, make her lunch, and run down and make her a cup of tea. Or so,
Yeah.
there's seasons.
Yeah.
But I kind of miss the interactions with,
Being
just
there.
even
Yeah.
seeing you guys, just like coming in and
Exactly.
out. But
Yes.
there are seasons for things, and this is where I need to be right now. And um,
Yeah.
so,
That makes sense.
life, right?
Do you,
You just
do you
you just
spend
make it
most of
work.
your time in Florida?
No, it's really, I mean, I am a
Okay.
Florida resident, so I am supposed to
Yeah.
be here, 181 days of the year. I'm
Right.
not, but
Hmm.
but I'm in and out a lot. I mean, and this summer I'm here for 6 weeks now. I'll be here for 5 weeks, two
Okay.
more times during the summer because I took clients down. I had a bunch of repeat clients down here. So I went ahead and took them. And yeah, so
Okay.
I'm back and forth. And this summer, like right now, I don't have my mother-in-law with me, but I'll be bringing her down. That'll be interesting to see how that goes because,
Yeah.
she's got some dementia. And I, I'll have to, I feel like I'll need to get down here early in my client's window so that I can spend a lot of time with her here in this house, in this space, to settle her.
Getting her
But
used to that. Yeah.
yeah, yeah, you know, um, I learn a lot from it. I must say, I learned a lot
Or
from this season about about myself and about caring for her. And
I'm
it's
sure.
very, very, very interesting how her brain works or not work so well.
Yeah. Yeah.
It's very
And
interesting. But
are you guys her main kind of
yeah,
caregivers right now? Yeah.
yeah, yeah. You're looking at her.
I mean, what an
You're look,
amazing like gift for you to give, but that's also stressful and that's a lot for you to take on.
yeah, in some ways she's very easy, and in other
Hmm.
ways it can be challenging,
Yeah.
but it's okay for now. It works for now.
Yeah.
Um, but yeah.
Aw.
So it's a little like having a toddler, only I can leave her at home. And
Right. Hmm.
she won't
How,
touch anything. Like she will not even turn light switches off and on
oh,
because
really?
she's afraid of using the electricity. Or like, I
Okay.
don't worry about her burning the house down. She'll never touch the stove, never touch the microwave, so
Hmm.
that's a plus.
Hmm.
But at the same
Hmm.
time, she won't, she doesn't remember to eat. She doesn't remember to cook she would never cook for herself, type of thing. But
Okay.
it's okay. It's okay. It's
How
life
long
at the
ago was
moment.
she diagnosed?
She's never had an official diagnosis. We
Okay.
we brought her over from South Africa 3 years ago this August. It'll be, or
Okay.
July 3 years ago. Um,
Okay.
and because it was becoming clear that, like, oh, she needs help.
Hmm.
Um,
Hmm.
so we kind of, at the time, I felt a little like, gosh, are we elder kidnapping? I don't know. I mean, Tom and his brother-in-law, they swooped in, grabbed her, put her on a plane, and brought her back.
Okay. They're like, we're doing it. Hmm.
Yeah, we're doing it. We're doing it. And it was, it was just one of those things where they went over with the intention on checking in on her. And when they got there, they were like, oh,
Oh,
this is what we're dealing with. And so
okay.
literally within 1 week, amazingly got her visa, put her on a plane. They
Wow.
got on, closed up her house, packed her up, put her
Wow.
on a plane with them. Yeah. And said, we're bringing her. I was like, okay, game on,
Oh, wow. So that was a big adjustment for you real quick too, to go
it
from thinking
was,
they were
but
going to visit to,
yeah.
okay.
So like, oh, okay,
Yeah. A new roommate.
okay. Yeah,
Hmm.
yeah. So anyway,
Where
I
does
wanted to let
your
you know.
brother-in-law? Oh,
Oh,
yeah, go ahead.
my
Okay.
brother-in-law and sister-in-law, they live in North Carolina, in Clemson.
Okay.
And that is a challenging relationship for my sister-in-law and her mom.
Okay.
My sister-in-law does amazing with her, but her mom, my mother-in-law, she has a lot of like childhood trauma that has spun right around. Yeah.
Yeah,
So
gotcha.
like she is with her right now. She's staying at their house right now, but we don't do
Okay.
that for long because it's just really tough on everyone.
Sure.
Um, yeah.
Sure.
Um, let me let you know that in about 3 minutes, I start letting people in and I'll let them come in, let them come in, let them come in. And then I will do a quick little introduction and then I will say, and Maggie, I'm going to let them tell about yourself, like like you introduce what you want them to know about you.
Okay.
Um, just because I think that
Perfect.
that tends to work better than people to share what they want to share um,
That sounds
and
good.
not what they don't. So yeah, yeah, yeah.
Perfect.
But
That
anyway,
sounds good.
yeah, I miss being at the nest. That was very fun.
I know, we miss you. I was walking in the other day and I was like, oh, because you're like the
The
nameplate thing
sign is
is
still
still
up.
on the building. Hmm.
I I noted I saw that the other day in some social media post. I was like, oh my gosh, my thing's still up there.
Yeah. Yeah.
Okay.
I mean,
Yeah, we'll take we'll
exposure.
take it.
You never know. Yeah,
Yeah,
exactly.
yeah, for sure. So um it is interesting. I mean, I teach my classes like postpartum recovery. I teach over at the Kingston Pike location.
Okay.
And this summer, I'm actually doing 2 of the series I'm going to do virtually, which I haven't done since COVID,
Oh,
but
okay.
um, it'll be good. It'll be good. Yeah, I'm going to start, well, in another
Okay.
minute or so. Let people come in.
Okay.
But yeah, um, I will have to send you the link for that series to
Yeah,
share with your people if they're interested.
absolutely.
It works,
Please do.
it's always interesting. I originally really thought that that would be a lot of like the physical recovery. And I have so many
Mm-hmm.
moms that they'll say even like, I, I came because I thought I needed it for the physical recovery. And what I didn't realize I needed was the emotional recovery
Yep.
and the community. Um,
Yep.
and that makes me really happy to hear, but it's
Yep.
like, we need the Emily Paces, we need the
Yep.
Maggies, we need
I know
everybody.
it's right. It takes a village, literally, and that's a part of it, is taking
Mhm.
care of the moms
Yeah,
too, not just the baby.
yeah, that
Yeah.
is for sure. So my glasses broke this morning, so I probably won't wear
Oh,
them, which means I'm a little blind going in, but I'm going to start letting people in.
okay.
Yeah. So, hello, hello. I'm so glad you guys are here. As you come in, won't you let us know in the chat where you are from, what you do, what you're hoping to gain from today's session? I'm so, so happy to have Dr. Maggie Klotz here with us, and she'll be really sharing so much goodness with us about maternal mental health, giving us some tips and some strategies that we can use with our clients and just really boost our knowledge as we go about our business of helping others. So again, as you come in, please let us know where you're from, who you are, what do you do? Are you a doula? Are you a provider? Childbirth educator, a mom? All of it is good, and all of you are welcome to be here with us. It just is awesome to have you here and to really help you grow in your knowledge of this subject. Maggie and I were just chatting about how it really does take a village. For me, as a perinatal fitness professional and as a doula and a childbirth educator, I just so appreciate the folks like Maggie who work with maternal mental health, and the folks who are, our pelvic floor PTs and our OTs and SLPs. It's just really helpful to have everybody in it. Selena, glad to have you here from Canada. You're a birth and postpartum doula. That's awesome. And Alicia from St. Louis, super. Doula and childbirth educator. Yeah, it's going to be helpful for us to really just see who all is coming in. And then that way, if there are ways that that Maggie can really direct her information for the listener and the attendee, that's going to be helpful to her as well. So Nikki, welcome. You're an assistant nursing professor. Okay. Wow. In North Dakota, was a labor nurse for 15 years, hoping to use this to help build on holistic clinical skills for her students during maternal health. Super. And Almitra, really glad to have you here from Memphis. You're a full spectrum doula, childbirth educator, lactation educator. Mercy, girl, you do a lot. Perinatal fitness and yoga instructor. Love that. Janice is a birth doula. And are you from Alberta, Canada, or from Alabama? That's what I wondered.
Alabama.
Caroline. Okay, hey, well, welcome, welcome. Glad you're here. Glad you're here. And Caroline is from Ohio. She's a birth doula and childbirth educator. So looks like we've got a bunch of birthy folks in here, and that's always great. We finished our Fit for Doula session this morning, and we were just talking about the importance of networking and really communicating and communing with other workers in our same interest, in our same field, maybe not identical fields, but because we all need each other in this collaborative effort to help our clients and our patients. Kristen, glad to see you back. She was in Fit for Doula this morning, as was Kendra. And Catherine, glad to see you. She's a birth doula and a CNA from Florida. Dusty's here. Dusty, good to see you again. She's from rural Kentucky. Go, girl. You've got a lot of work to do there. I know from some of my friends that they've really been working on getting birth centers and really boosting the childbirth support in Kentucky. And Wendy is from Wentzville. Wentzville, where? Where is Wentzville? What state is that in? We'll have to learn. Bonnie, glad you're here. Thank you. You're an RN, IBCLC, OBGYN office. Yeah, I'm sure that you're going to be able to get some really great information to help with the patients that your office sees there. That's fantastic. We'll give it about 1 more minute, and then we'll get started just to honor everybody's time. When you have questions, go ahead and post them in the chat, and we'll track them. And at the end, we can open up for the Q&A session. We also have some handouts during Maggie's session that will be dropping into the chat at the appropriate time. And then at the very end, if I remember, I will drop in the CEC, but that will also come in your email afterwards. So without further ado, I want to introduce Maggie. She is a maternal mental health counselor up in Knoxville, Tennessee. We got to know each other because for a while there we sort of shared office space in a building called The Nest, which is a place up in Knoxville, Tennessee that really focuses on maternity care from pelvic floor PT to childbirth educators to IBCLCs to Maggie's group. My office for fourth trimester fitness method was in that space for a while. And so I'm so grateful that she agreed to come here and speak with us today. So Maggie, I'm going to go ahead and let you talk more about who you are. If everybody, when you come in, if you aren't already on mute, if you would go ahead and mute yourself, that would be helpful. And I am going to do the same. So welcome, Maggie.
Thank you so much, Emily. Um, Thank you for that introduction. Like Emily said, I am Maggie Klotz. I am a licensed psychologist, and it's seeing everyone coming in. I'm really excited to be here. Thank you for taking the hour out of your day to do this and want to learn about this topic today. I am really passionate about it. This is an area clinically that I work with a lot. I have a lot of clients who I work with individual therapy, doing group therapy, support groups for people, but I myself am also a mom, and so going through some of these things throughout my personal life as well. It's just a topic that I'm passionate about, both professionally and personally. So, um, thank you for the opportunity to allow me to be here and talk about this. So today, what I'm hoping for when I think about, let's see, there we go. Um, if there also, before I get started, if there's any issues, like Emily said, throw out any questions, and I want to make sure I address as many of those as I can at the end of the presentation. But if there's ever, like, if you can't hear me or if we're having trouble with the slides, just feel free to let Emily know, or Emily, feel free to yell at me and I'll figure that out. But so in terms of what I hope for you to gain today, um, I came up with a few goals of today's presentation. I hope that after today, you're able to be more familiar and identify symptoms of some of the perinatal mood disorders that you might see. I'm going to talk about the ones that I think are the most common. We'll also talk about a couple that maybe a little bit less common, but more serious that we do want to know about and be able to identify. I also hope that everyone by the end of today feels more comfortable with their ability to administer. We're going to talk through a couple screening tools that can help if we use them on a regular basis with clients. It can help us, gain information and let us know anyone who might be higher risk, and that might also be a good candidate to refer to some support services or therapy. And then finally, just feeling more confident actually having that conversation with someone. So, how do you actually bring that up and say, hey, I think it sounds like you might be struggling with a few things right now. And therapy might be something to look into. Emily, I saw you unmuted. Do you need any?
I did. I do. I just need to say that we need to share the screen again. Currently what's showing are your notes. So if you want to show yeah, just so it's not as distracting.
Let's see. Let me try something real quick. Sorry
Sure
about
thing.
that.
That's okay. That is okay.
Mm. Let me try this, and then can you still see my notes?
We can.
Okay, let's see.
I think if you go to presenter mode and then presenter view.
Hmm. Mm,
I think now we're seeing the full screen without the notes, Emily.
Okay.
yes. Let me hold on. Sorry about this. Let's see.
That's okay. That's okay. I will just let you know that I'm glad it happens to you too.
Uh-huh.
Because
I mean, of course.
yeah, it happens to me too. I'm always like, what screen is everyone seeing? I have no
Yes.
idea.
I know we had it
Um,
figured out too.
we did,
Okay,
we
so
did.
just
There should be a present option Dusty is sharing.
where let's
Let's see. So right now I see like if you go to your options to choose from, when you go to
mm-hmm.
present, you should be able to choose which screen it
Mm-hmm.
is sharing from, and then you should be able to choose whether or not you're sharing like your entire desktop with it or just, and you're not sharing don't worry. But you should be able to share just the presentation deck.
Okay. For some reason let's try this.
Yeah, no worries.
Okay, this is presenter view, but I think you guys can see the
So
notes, right?
then, right.
Let me try. Okay. You know what? If in a second I'll wing it without the notes, it's okay.
Okay.
Mm,
This is just real life. That's all.
You had it before, Maggie.
yes.
Yeah, there was a moment where we could see it before.
Okay. Okay, hold on. Ooh, ooh.
It's that
Oh, we're
little
getting there.
icon
Oh,
where it's the double,
yes.
um, the little squares, the one next to it would be presentation mode.
Yes. I was right there, but I don't know. Okay, here. Here we go. Now what can you guys see? Anything?
I'd rather
Um,
see the notes than
we
nothing. So
It's still
Yeah,
the
we don't see
notes.
anything. Yeah, so go back
Okay.
to
It's
your
okay.
screen. And Victoria says she can help now if you need. Lori Lawrence says she's been at her computer since this morning. She's still in her pajamas, so she's not being on screen. That's okay, girl. We all are in various states. It's okay.
Yeah, Emily, I know too. I know you have the slides too. If like we need to present as 4TFM, we can just advance through them for
oh, that's fine.
Maggie. Oh yeah, here you go. Yeah.
Okay.
Presenter view, yeah.
Yay. Almost
But
got it.
then do you have two screen Maggie, are you working with a desktop with two screens?
No, I wish.
Okay, that could be okay. That's the problem then. There, I don't know if there's a way to show, because I think the presenter view is kind of meant for if you actually
Gotcha.
go back to sharing, or actually if you go back, if we start the screen or go to your screen share on Zoom, you can change it to where just the window with the PowerPoint is shown, and you should be able to see your screen, like your notes. But I know sometimes it's easiest if there's like two.
Let's just do this, guys. It's okay.
Okay, just do perfect. Yeah.
Yep, we're just gonna
And
do
thank
this
you,
and it's
Brenda.
okay.
Oh,
Yeah,
there you go.
that's most
You
ideal.
have
There you
it.
go.
That's
Yes.
okay. I don't have my
You're doing
notes,
it.
so I'm just winging it, y'all, but that is okay.
Perfect.
We got it.
Yeah, we've got it.
We got we
Okay.
got it. Yay.
Yes.
Okay.
You're welcome.
I may pull something up in a little bit so I can see my notes in a different way, but that's okay. I can't see my notes right now, but it's okay. Okay. So yes, over
Welcome
goals
back.
and objectives. Yes, welcome back. Sorry, everybody. This is story of my life with technological difficulties. But thank you for letting me know, Emily. I appreciate it. Okay. So, the agenda, the few things that I just want to kind of give you a roadmap for what we are going to talk about today. First, just going to talk about, like I said, the most common kind of perinatal mood disorders, mental health disorders that you may see. Go through just the symptoms of that so that you know what to be listening for when people may be talking about just kind of their day-to-day life. You can be listening for symptoms that they may be talking about. I also want to talk about, a little bit about like why do these things come up during pregnancy? Why do they come up right after pregnancy? Because I think those factors are also really important to know about, because it also plays into those who might be more at risk for some of the disorders that they might be at higher risk for. So and then finally, like I said, we're going to talk about how to actually go about having those conversations. And then I know, since everybody's kind of located in different areas, um, I want to talk about like, how do you actually find providers? And you all probably know people in your areas where you are, but how do you identify like who are the mental health providers who specialize in this? And how do I have kind of like go-to people that I know that if I do need to make a referral, where, or who do I refer them to? Okay. So perinatal mood disorders, obviously, I mean, some of the stuff I know that you all already know. The perinatal period is going to be during pregnancy, and then different organizations kind of define this in different ways. I would say like anytime within that year, at least after giving birth. It can also be post loss as well. So if there's a miscarriage, if there's a pregnancy loss, infant loss, these same types of symptoms and disorders you may see as well. And so keeping an eye out for that as well. I'm going to go over depression, anxiety, obsessive compulsive disorder, PTSD, so post-traumatic stress disorder, bipolar mood disorders, as well as perinatal psychosis. So, perinatal depression, so I'm going to talk about depression and anxiety first, because those are the ones that we are going to be the most common for you to see, but also, I think that these are also going to be the hardest ones to kind of tease apart. Is it just kind of the normal, like adjusting to having a new baby at home, or having another child at home and going through that adjustment? Or is it actually something that's more clinically significant that I want to pay attention to, and I really need to make a referral and kind of suggest that they get some further support? So you always hear about baby blues, right? And so it can be really, really normal for right after giving birth, when those hormone fluctuations are happening and there's that huge hormonal drop, for people to experience a lot of mood swings during that time. And so there can be a lot of sadness, like crying all the time, probably more of that irritability, anger, the first bullet point, probably all of that you're seeing. Usually we think of the baby blues, that kind of period where you're gonna expect the mood swings and sadness, anxiety, all of that to be really heightened. You're going to expect that to kind of resolve, or at least you're going to see some improvement within a couple days to a couple weeks after giving birth. And so I would say if it's continuing past that time, to be paying attention to, maybe it is more significant at that point. But so obviously depression symptoms, it's going to be the same type of symptoms as you think of as depression, but feelings of sadness, depressed mood. I always say it's easier for us to feel angry than it is to feel sad or more vulnerable emotions. And so someone might have a depressed mood. You may see that coming out as like I think of my own time, I was probably like yelling at my partner all the time about things. And so like that anger, irritability, increase in that. There can be a lot of guilt, shame potentially coming up. Again, some of the stuff can be really normal during that postpartum period. But if it's happening kind of most of the time, all day, most of the week, that type of thing, you want to really pay attention to that. If you notice someone saying that they're not bonding with their baby, if they're having like a lack of interest in, being with their baby, again, there can be a normal adjustment period. But if that continues, or if it feels like they are really distressed about that, those are all things to kind of pay attention to. Any changes in eating or sleeping habits, that can go either way for either of those. It could be having no appetite at all or eating all the time. It can be not being able to sleep at all or, sleeping more than usual. But if there's a major changes in either of those, trouble concentrating or focusing, feelings of hopelessness, and definitely if anyone ever talks about thoughts of harming self or baby, obviously that's something you want to pay attention to, and that's going to, warrant a more immediate intervention and referral somewhere. And we're going to talk more about that piece specifically of how to address that and talk with someone about it. Perinatal anxiety. So anxiety, there's going to be the extreme worry or fear. There might be a lot of restlessness that they are feeling. Again, the irritability, there's some overlap between anxiety and depression. And people can be experiencing both of these at the same time too. So, again, those sleep or appetite changes. With anxiety, there may also be some panic symptoms. A lot of times, panic symptoms people feel in a very physical way. They manifest as physical symptoms. And so if you hear people talking about like shortness of breath, chest pain, tightness in their chest, if they've been feeling dizzy a lot, like a numbness or tingling sensation throughout their body, and overall feeling like they're losing control. One of the So there's been a lot of studies done, and again, you may know this, but panic attacks. So out of people who go to the emergency room and believe that they are having a heart attack, if it is not a heart attack, like over 90% of the time, it is a panic attack instead, because the symptoms overlap so much with each other. And I don't think I've ever had a client who has talked with me about a panic attack who hasn't said, I felt like I was dying in that moment. I mean, it is such a physical experience. And so I would say if you hear people talking about, having a moment where they're experiencing these symptoms, obviously, if they're having physical symptoms, you also want them to get checked out by a medical doctor. But, it could also be, something mental health related as well. Perinatal OCD, this is one that I think people probably don't think quite as much about. So obsessive compulsive disorder, there's going to be the obsessive or obsessional thoughts. And so those are going to be repetitive thoughts that come up over and over and over again. And even like if they are trying everything they can to distract and not think about whatever it is, the thoughts are intrusive. They cannot make them stop. And then usually there's very high, so OCD is an anxiety disorder. So it's very, very high anxiety about those thoughts typically. And then the compulsion part is doing something or avoiding certain things in order to reduce that anxiety. The hard thing is usually like OCD, I always say OCD is a disorder that has no logic to it. And so even someone who experiences it, they know this doesn't make any sense, that I like what I'm doing or why I'm thinking about this, but they can't make it stop. And so especially during that postpartum period, you might see like, let's say with the measles outbreak, if a mom is really, really worried about their baby getting measles and they are avoiding going anywhere, letting anyone see the baby, which okay, that all might be normal. They're staying at home, but then they're noticing like they're having to wash their hands at all times and wash their hands over and over and over and over again. And even if someone tries to say, right, the logic part of it's okay, like we haven't went anywhere, there's no way that the baby could have been exposed to this, they still have to do that. They still have to wash their hands so many times until that anxiety comes down enough for them to stop doing that. There's been examples of someone like changing their child's diaper and worrying about touching them inappropriately in some way. And so they just avoid changing their child's diaper. It can present in a lot of different ways. And there's already so much anxiety being a new parent and having a baby around and all the ways that things could go wrong. OCD is just going to be, obviously there's going to be that compulsion part to it as well. And the thoughts, like not being able to compartmentalize, not being able to kind of step away from those when you need to. So if you pick up on some of those types of symptoms, that's something to pay attention to as well. Postpartum PTSD, post-traumatic stress disorder. This is one that's probably more common than we realize even. So this is going to be, this can be from previous traumas, or if there is a childbirth or their birthing experience was traumatic or did not go as expected. A lot of times there can be postpartum PTSD related to that. Usually with PTSD, to actually have that diagnosis, there's going to be flashbacks, nightmares at times, feelings of anxiety, obviously. Always there's a component of avoidance, of triggers to that anxiety. And so it could be like avoiding going to the hospital where the child was born, or avoid going to that area of town, things like that, that are then, and that's where I say, like, when you're teasing apart, is this kind of a normal adjustment thing to being a new parent, or is this something significant? If it is coming in the way of your day-to-day functioning or your ability to just kind of take care of your basic needs, your child's basic needs, those are times where you really want to pay attention to it and think about, getting some more support around it. And then finally, the last two are less common, I just want to say, but I think also really good to know. So bipolar, I meant to change this slide, which is why I'm looking at it funny. So a lot of people are actually diagnosed for the first time with bipolar depression or mania during or shortly after pregnancy. A lot of times especially with mania or any type of psychosis, we think of if there's major life events, those can be times where you have kind of those breaks into mania or psychosis. And so that's why. And then with all the hormonal fluctuations as well, that can be kind of a trigger into that. But bipolar, there's going to be one of the biggest misconceptions about bipolar is most people think, oh, that's for people who like have mood swings and their moods are up and down, up and down. And it's more than just that. Bipolar is going to be obviously a depressive period, and then mania, which mania is going to be someone who's having a lot of energy, not sleeping at all because they just they're not tired, they're not needing to sleep. So they might go 2-3 days without sleeping at all or getting an hour or two of sleep. There might be more erratic behavior, erratic spending, or like impulsive decisions being made. Usually, if someone is in a full-blown manic episode, they also don't have a ton of insight into that happening. And so that is also something to pay attention to, of if like they have a support person with them ever and they're mentioning to you that they're noticing changes or things like that. So that can be important information to hear. Just because, like I said, when they're in a full-blown manic episode, they might not really be aware that there's been these major shifts. And then perinatal psychosis symptoms. Again, this is also, it's not very common, but this is going to be a more severe situation that you want to make sure that they're getting immediate help. So an complete inability to sleep if they are having delusions or hallucinations, so seeing images or hearing voices that others cannot. There might be a distrust of others, usually some paranoid type of thinking. They might think that someone's out to get their baby or someone's going to steal their baby. Periods of like real confusion, again, the mania, depression, memory loss. But these are going to be times where if they are hearing voices, especially and it's not always this, but if the voices or what they are seeing are destructive or harmful to themselves or babies, that can be a really a safety risk that they need some help right away. So the next part, like I said, I'll go through this pretty quickly, but I just want you to know that there's so many different factors as to why. Why do these things come up? Why do they come up during pregnancy and afterwards? And how does that kind of change the risk factors? This is a picture of my family right after I had my third child, and I put it here because I don't think the photographer meant to do this, but I was like, oh, it always makes me sad to see it because this was a time where I was like, this is exactly how I always felt, where I was like with the baby and taking care of him, which was lovely. But then I watched the rest of my family like having fun and living like our normal life. And I remember feeling such sadness at times. Like I missed just being able to like pick up my kids and run with them and play with them. And how often I felt like some grief related to not having my old life. And and I'll share a little bit more about that, but I think that is one of the reasons why I also feel so passionate about this because this is a specialty area of mine. I know what to look for. And even when I went through this in my own experiences, I was able to talk myself out of like actually acknowledging that I was struggling with some of the things that I was. I think I experienced full on perinatal postpartum anxiety, and I told my doctors I was fine. I told everyone I was fine. And the number of times I've wished like someone could have just said, "Hey, you seem off. Like what, why don't you talk to somebody? Why don't you get some support?" I think that could have helped me in a lot of ways. And so that's why I think with things like this, the more we can recognize, the more we can kind of see and not be afraid to say, "Hey, why don't you go get some support right now?" Um, you never know. And so the more people who know about this, I think the better, and the more people who can make that suggestion. Okay, so off that piece, but so obviously there's going to be biological factors, the hormonal piece of everything that's changing, our serotonin levels or yeah, the neurotransmitters part of it, everything's shifting with that, our hormonal levels. We are going to have some genetic predispositions to having certain mood disorders. If we have medical complications during the pregnancy or during the birth, that can also increase risk for developing some of these mood disorders. All of those things play into it. How quickly our hormones do kind of regulate after, that can play into whether or not a mood disorder develops. Psychological factors, if obviously bringing a new life into this world, taking care of a new baby is stressful enough, if you have additional stressful life events going on top of that, so let's say someone loses their job, or you are evicted from your home at that time, or you're going through a divorce and having a lot of relationship difficulties, all of those things increase the risk of developing some of these symptoms. Having a prior history of mental health issues before the pregnancy or birth, having previous trauma, or if like I said, if the birth and delivery experience was traumatic in some way, those can increase the risk as well. Having a lack of support, I think sometimes that postpartum period can feel so isolating anyways. And so if you don't have that support, and feel like even if I did reach out, I don't know who I would reach out to, the less people you have around you, the higher risk you are at developing some of these symptoms. If you had difficulty getting pregnant, that can go into it. Sleep deprivation, which that's like, that's typically happening for people during that postpartum period. But I always say, like, postpartum or not, anytime we're not getting sleep, it makes us feel our emotions and our symptoms. It just amplifies it and it exacerbates those symptoms. And so anything that you are feeling, any symptoms that they're having, if you're not getting sleep, it's going to heighten those. And then environmental factors. Again, the social support, socioeconomic factors, if there's financial difficulties, housing difficulties, like I said, the traumatic birth experience again, and then if there's any substance use addiction issues, that can also increase the risk as well. So I say all that to say, not that you need to memorize this and keep all of these things in your head at all times, but I think the more you're aware of some of these things, and if you pick up on, one of your clients is just talking about kind of life at home and how things are, how the adjustment has been. If you notice that they're mentioning some of these things, it's all a part of the puzzle, right? It's all things to kind of keep in mind and talk about with them. So, okay, just check the time for us. So like all of my trainings in grad school, everyone always came up with some sort of acronym for us to be able to remember things. So I tried to do this, and the best I could come up with was EAR. So I apologize. I was hoping to come up with something more catchy than that, but that's why at the beginning it says put on your listening ear. So you know all this information, you're thinking like, here are the symptoms I'm kind of paying attention to, but then what? So how do I actually like talk to my client about this, make a referral, have that discussion with them? And so I kind of broke it into a few different parts to help you with this. So the first part obviously is just empathic listening, but really just being there with your client. I oftentimes, if I've ever asked people, so I used to train psychologists a lot who are in grad school, of kind of the beginning stages of learning how to be a therapist, and everyone always wanted to like know like what I need to know what to say. Like you want that magical thing to say to make someone feel better, and there isn't that typically. Like sometimes we can't solve what they are experiencing. And so trying to let go of that piece and knowing, typically if I ask people, like, think of a time in your life where you reached out for help or support and someone showed up for you, someone helped you. What was it that was helpful? And most of the time it wasn't like something specifically that was said or done. Most of the time people end up saying they were just there, like they just showed up essentially, and knowing that they were there was really helpful. And so even in the moments where you're like, okay, I don't really know what to say next, know that just being there with them and showing that you're not judging them, you are understanding what they're saying, that goes a really long way. And so if you don't know what to say, fall back on just being human and sitting with this other human and helping them through this moment. I always say like open, as much as you can ask open-ended questions around these things. Keep them talking, like get as much information as you can of how they're doing. I know that things are timed for y'all, and so like you may not have all the time in the world to get all this information, but ask as many kind of open-ended questions as you can. So like how have things been going since bringing baby home? Like, how has life changed for you? And just open it up like that rather than, so has it been really hard? That's going to be a yes or no question, and then it's going to shut down, and you got to come up with the next question. So just try and keep it open as much as possible. Minimal encouragers are just the things that you do when you're sitting with someone and you're nodding along, you're saying like, and I understand. It's the small little things that you're doing that are showing them like, I'm here with you and I'm hearing what you're saying. And again, just having patience with them, understanding, expressing that. And I think more than anything, like as they're saying things, if they are struggling, making sure that they know that like no matter what they say, this doesn't say anything about the type of mother you are, how good you are as a parent. You are doing everything right. And, let's talk about how we can take care of you right now. And so that is the goal, but making sure that they know, like anything that they say, it's not a reflection of who they are as a human or as a parent. The next part is really just some screening tools that you all may already be familiar with, but I do think can be really helpful tools. Obviously, knowing some of these symptoms, but these are screening tools that are, you know, researched, they have been validated, and are pretty easy, quick tools that you can use with clients. And quick to score. It gives you a really good snapshot of should I make a referral or should I not? Should I ask some more follow-up questions or should I not? So I focus on depression and anxiety since those are the most common ones, but there's the Edinburgh Postnatal Depression Scale. This one, I don't know how well you can see it. Uh, Emily is going to drop this into the chat, I believe, but also you'll have access to PDF copies of this, as well as I created like a scoring sheet for you because there wasn't one that I could find very easily. But this scale is quick. It's 10 questions, so it's really fast for a client to be able to fill out. And then it's really easy to score. So you essentially score it 0, 1, 2, 3 down, and then the ones that have an asterisk by it, you do reverse scoring. So then it goes 3, 2, 1, 0. Like I said, I'm also gonna have available the scoring card for you so that you could always have that available and know how to score this. But essentially, how to score and interpret it. Typically, actually, the research has shown that at 13, if a patient or a client scores 13 or above, that is going to indicate that I think research has shown that there's like an 80% likelihood of them having clinical like depression, major depressive disorder. The section of that is 9 to 13. And so I usually just say if they score within that 9 to 13, so I put it a little bit lower. I say if a client scores 9 or above, go ahead and think about making that referral. And then number 10 indicates suicidal ideation. So that is the question that they ask about that. And I always say if they score 1 or higher, so unless they say they never think about suicide at all, that is also a time to talk about a referral. All of that to say, you could have them fill this out and then, but based on what they have said and what they've talked about, you're like, I don't know, I'm just picking up on something, like something's off. They've talked about X, Y, or Z. Don't ever ignore your clinical judgment on things as well. So if you feel like something is going on, you're not going to hurt anything by suggesting that they talk to someone or get support. So trust your gut and go ahead and make that referral as well. And then the second screening tool that I wanted to talk about is the CAS. It is the anxiety let's see, the postnatal anxiety screening scale. It is a little bit longer. I believe it's 31 items, so but still relatively quick for a client to be able to fill out. And then easy to score, same type of scoring. You'll see 0, 1, 2, 3 across the board here. You can score that. There's also tools online that you can find that they could fill it out online and it's scored automatically. But even if you do it by hand, it's pretty quick. So it assesses 4 different areas of anxiety, as you see: acute anxiety adjustment, general worry and specific fears, perfectionism, control and trauma, and then social anxiety. This is going to be the score could fall anywhere between 0 and 93. I would say if it falls in that mild to moderate anxiety or higher, so if they score 21 or higher on this screening tool, again, that's a good cue to let's go ahead and make a referral. Again, pay attention to your judgment as well. So even if what you're seeing on this scale feels off from what you are hearing from them per their report, go ahead and make the referral. So I added this in kind of last minute today, actually. I just wanted to put a little bit of a caveat on. Okay, so if they mark an item about suicidal ideation or they mention something about having suicidal thoughts, what do you do? I think a lot of times people get nervous. They don't know how to ask about this more. And one of the biggest myths around suicidal thoughts and suicide is, well, if someone wasn't already thinking about it and then I ask them about it, what if that puts that into their head and then makes them start thinking about it? And research has looked at that and studied that, and more than ever, people find it really relieving, actually, if someone just opens that door for them to be able to talk about it, and it's done in a normalizing way. And so if someone's talking about feeling really depressed, or if they do, um, if they mark an item about suicidal ideation, following up about that, you can ask more questions of, how long have you had those thoughts? Have you ever attempted suicide in the past? Do you have a plan right now? I think because if someone is actively suicidal, if they start saying that they do have a plan, they want to act on it, they need immediate help, right? It's not just a referral to like follow up with this therapist at a later time. At that point, like, we're needing to probably call 911, call a like crisis mental health service if that is available near you. But it's an emergency if someone is actively suicidal and you need to call an emergency number. The majority of the time, it's going to be some level of passive suicidal ideation where they have thought about it. It's kind of the thoughts of like, if I didn't wake up in the morning, like that, sometimes that feels okay. Things like that. And so you want to talk about that and then again, make the referral. I don't ever want, when talking about the mood disorders as well as suicidal thoughts, it's not your job to have to figure out, what is the treatment that they need, what do I do next. You don't have to know all of that. I think the biggest thing is just showing them understanding, normalizing their experience, and really trying to get them to follow through on getting mental health services. And so finally, the last part is really how do we make these referrals and talking through that piece with them. So when bringing it up, I always say, like, it's not something, there's a stigma sometimes around therapy and mental health services. And the more direct we can be about it, the better usually. So, I usually say, especially new moms and new parents, even just talking about like, you are giving to everybody else right now. You have been taking care of everyone else around you. Who's taking care of you? And what are some ways that we can, take care of you more? One thing and the more you can use like your own experience or, clients that you have worked with, obviously you don't have to say names of people that you've worked with, but sharing, like, I have worked with a lot of people who have struggled with the same things that you have. And one thing that has always been helpful is, finding support. And that might be therapy, that could be psychiatry, looking at medication, that could be support groups. There's a lot of different things available. Why don't we talk about some options around us that might be helpful? Normalize their experience. The more you can kind of instill hope that, I know that things feel really rough right now, but like I said, I've worked with a lot of people who have dealt with these same things, and it really does get better, especially if you can get some even more support in your life around these things. And then I always say, like, if you can have a referral list ready to go to give to them, to talk through, already people that you've kind of looked into and you trust, the better. And that way you're not having to do that work there in the moment. And that's ready to go. So I tried to help with that piece a little bit today. I came up with a handout that you can use if you want, or you can pull what you want from it. But I created essentially a handout that talks through some of the common symptoms we've talked about today so that that can help normalize their experience. And then some treatment options at the bottom. I made this in Canva and made it so that you can change this bottom part. Even if you don't have Canva, you can do this with the free option. You don't have to have the premium version, but there's a link that we'll send to everybody that you can open it in Canva, and then you'll be able to change the providers. These are providers in Knoxville. So if anyone's from Knoxville, these are some great options. If you're not from Knoxville, there's still some the Postpartum Support International, anything by them is a international group. And so those will be available. Those are all online resources. So those are available to everyone. And then I'll talk about one other thing in a second, but you can add your own logo to it. You can change these and have this as a handout if that feels helpful. I just put this here. I'm not going to go through this exactly, but this is this is what recent research has kind of shown in terms of treatment recommendations for postpartum depression. And basically the takeaway is usually it is some sort of combination of therapy and or medication. And so that is why on the handout that I made, I have 3 different categories of resources that might be helpful in terms of mental health. So there's individual therapy, psychiatry and medication management, and then support groups. Support groups oftentimes are going to be a lower cost option for people. A lot of times you can find free support groups. And even if they're not run by a licensed mental health provider, it can still be really, really normalizing for someone to be with other moms or parents who get it and are going through the same thing. And so that's also a really, really good resource. So when you are trying to find, okay, well, if I'm going to use this handout and I want to find therapists or people to put into the section that is geographically where I am, I would say I always recommend, especially for maternal mental health, 2 different ways to find these things. So again, there's the Postpartum Support International. That is one of the gold standard for mental health providers. It is a training that mental health providers go through, but they also have so many resources on their website, and they also have a list of providers that you can search by like Orlando, Florida, and they'll have both psychiatrists as well as psychologists and other mental health providers listed that are in that region who have been trained by PSI. And that is a great, like if they have that certification, they've received great training in this area. And so that is one way to do that. There's also plenty of providers who haven't been certified by PSI, but they have training, they specialize in this. And so I would say the other way to search would be through Psychology Today. And I was going to share this screen, but I'm scared based on my previous experience of my screen share. But if you go to Psychology Today, that's like the #1 website that I say to use when anyone's looking for a therapist, whether it be maternal mental health or not, because you can search by area, like I can go to Knoxville, Tennessee, and then you can go to filters and you can filter by anything. Like you can say, I want to work with a women identified therapist who is LGBT affirming, who he works with religious trauma and birth trauma. I mean, you can click so many boxes and find a therapist that, I mean, falls within those categories typically, depending on how far you go. But especially like there's a little screenshot here. There's one that you can find this pregnancy, prenatal, and postpartum. So even if you went to your geographical location and click that box, you'll get a lot of therapists that come up. And that's another great way of looking. You can find psychiatrists as well as mental health therapists. So I think that is everything. I was kind of flying at the end because I know that we're short on time, so I apologize for that. Let me open things up for questions that people have. Let me see if I can look at the chat.
Maggie, I started trying to take notes of some of the questions coming in. They were so good.
Yes.
Thank you so much for this presentation. Golly, it's just filled with superb information. Really, really enjoying it. One of the questions was, should we give the Edinburgh scale before birth, like maybe in our prenatal visits, should we discuss this with our clients during that time?
Yes, I think that
Okay.
I would recommend giving that throughout pregnancy. It doesn't have to be every time. I don't know how often you see them, but even to have, if you do see them during pregnancy and some follow-up, to have almost a baseline and a follow-up, that's great information to be able to compare the two. But if they're experiencing, depression during pregnancy, you might get that information earlier, which the earlier the better too, because there's a lot of options they can do before baby gets here so that they have that support as early as possible. I think that's a great idea.
Mhm. Cool, thank you. And then Almitra just made a comment that there are lower cutoffs are suggested for Black women and birthing people when using the EPDS. Can
That
you
was a
speak to
really
that, the lower
great
cutoffs?
question. I don't know exactly, but I can probably send a pretty quick follow-up today. I know that um,
Great.
I did look at it being validated on a lot of different populations. It's been around forever, so I know that it has been. Let me look at standardized cutoffs for different populations and see if there are different cutoffs. Because I know that I just found some information around that, as well as some translations into different languages for each of these scales. And so I can share both of those in case either of those would be helpful. But I don't know
Yeah,
off the
that
top
they
of my
would
head,
be.
but I would be happy to send those over to Emily afterwards so that she can share
Yeah,
them with you.
that would be great. Thank you.
Absolutely.
Victoria
Yeah.
wanted to know if you would speak to the difference between OCD and hyper new parent vigilance.
Oh, that's a great question. I mean, I think again, it's that what is the like what's happening in that adjustment period of being a new parent and what is coming up mentally, emotionally during that time that is a normal part of that adjustment versus something that is more clinically significant that is going to last long term. I also think like with OCD specifically, you are going to see um, OCD can kind of take over in a lot of ways. Like especially if there are compulsions that are involved, it can interfere with day-to-day life in a really, really significant way. And it's not that that hypervigilance can't as well, but it's probably going to be at a higher level. Um, to my knowledge, the hypervigilance new parent, I don't think is going to have a true compulsive piece to it. There's probably a lot of that obsessional thinking and constant like worry of, your mind can get really focused in on a fear of something, and it's hard to pull your thoughts away from that. But usually there's not the compulsion piece to it, and I could be off on that, but that's what first comes to mind.
Yeah, I think I can relate to that question because I feel like a lot of times, especially with our first time parents, it's like we all know that like the more children you accumulate, the more children you accumulate. But with those first babies, we tend to be so hyper focused on everything, and I can imagine that there could be the fine line between first-time parent hyper focus and moving into the OCD realm of things.
Oh, absolutely.
Are there some good questions that we could ask of our clients if we feel like we're observing anything that might make us wonder?
To differentiate between the two.
And Maggie,
Yeah.
that was I can like give you an example of like what I'm thinking
Yeah.
of. Like that was my
Yeah.
question. And thank you. This was like super, super helpful.
Yeah.
I'm seeing a lot more parents like, have like really like during COVID lockdown, you saw lots of like, you need to wear a mask before you come over and like sanitize your hands. To me, that made sense, kind of in the middle of the thick of things.
Mhm.
But since then, I have seen a lot of like tension in families of like the mom is saying, well, no one can come see the baby, right? Or they're gonna have to like quarantine for 2 weeks just in case they make sure they don't have a sickness, and I usually the parents don't agree on this. And I do feel like, gosh, that's so hard to know. Like, is that kind of a sensible precaution? I mean, this is a new baby, like what's sensible and what's like, that seems a little like overly OCD hypervigilant to me. And I get it, I get it like on all I I
Yeah.
I get it. I get it from kind of every direction. Or the mother, I've had a mother-in-law be like, go tell my daughter to like let me see that baby. And I was like, hey, that's not my role. Mr. There's trying to keep your little grandbaby safe and healthy. But it really is tough, because that's the
Mhm.
specific way I'm thinking of, or whatever, when parents really worry about one thing or the other. It's like, is that just
Yeah.
my parent, or is it like anxiety, OCD, hypervigilance, signs?
I think
Thank you.
that's a great example. And I do think, I mean, when as you were talking through that, Victoria, I actually was thinking like, that might be anxiety. It might not be specifically OCD, but it could be really, really high anxiety about just kind of generalized of like anything that could happen to baby, like you said, that hypervigilance about everything. Um, and either way, even if it's anxiety or OCD, I think it could be helpful. Like in those examples, I would think that could be really helpful for them to go talk to someone about it.
Yeah.
Either way. Um, yeah, and I do think a lot of different like factors that I kind of talked about too. Sometimes those are at play and we don't even realize like if someone had a miscarriage or someone has been in social media or the news and all they, like my For You page, personally, my For You page is my literal nightmare. Like all it tells me about are children who die or moms that have cancer and die. And I mean, like I say that kind of jokingly, but it is, I mean, I know that that has an effect on me and it makes me worry about all these things that could happen to me or my children. And so that can all feed into all of that anxiety. So I also feel like in like the social media age and everything right now, there's a lot that can feed into heightening that anxiety for somebody. And if they could go and talk with someone and talk about ways to like, how do you turn some of that off and
Yeah.
be present and that sort of thing that could be helpful for them.
Yeah, that's good.
That's really good. Yeah, thank you so much. First of all, I want to just let you know, Maggie, that the comments have been really, really good. And, this has been so very helpful and feels very attentive and also less intimidating when trying to be helpful to clients. I think that's, I think probably a comment that a lot of us are feeling right now. I certainly am. But there was a question, a few people asked about, could you speak to maybe the risks of partners, like to the partner? And also, like, are they at risk as well? And then are there resources for partners?
Yes, absolutely. I'm glad that people asked about that. Yes, I think that in some ways, a lot of times, right, the partner can feel forgotten in a lot of ways, and that can feed into some of what their adjustment looks like and what they experience during pregnancy as well as postpartum. And so all of the diagnoses that I talked about, that can be true for, and that's why at times I say mom and then I try and say parent because I think it can be either. It can be any parental figure that is involved. So any of the diagnoses that I talked about can be true for either partner. And the harder thing might be identifying that sometimes because if they are not your client, how do you kind of have access to them and how do you get them to, how do you make that referral? But let's say you have a client who might be talking about like I'm doing okay, but my partner seems to be really struggling right now. I think you can still talk with them even about, what this affects partners as well. And the same thing that the same resources that could be helpful for you right now can be helpful for them. And so there are like individual therapy, I mean, the psychiatry, individual therapy, those are both options for partners. But there are also support groups for partners as well. Especially if you go to the Postpartum Support International website, there's all of them are free. They're all online. So anyone, anywhere in the country can go. And I know that there are some specifically for partners available through that. And so that would be a good resource. I would suggest if anyone does use that handout, leave that one on there for sure. Because that's going to be there's so many different options for different scenarios and different things that people might be experiencing.
I dropped some of the links again and some of the PDFs into the chat for you folks. So feel free to grab those. Let's see. Oh yeah, Lauren says partner support is huge. Walking through a mental break, hospitalization, medication for a client right now. Dad has needed serious support, and they started couples counseling as well as individual counseling. It's much needed. It's much needed. Yep. Bonnie says, thank you for the tools to be able to look for help in each state. There's never enough help out there. And I think that's so true. I think a lot of times, go ahead.
I was just gonna say, Emily, I mean, I'm happy. I don't know if people have access to my email, but I'm happy for you to share my email with the group. I think that I agree, especially right now, there's like a shortage of mental health providers, and it can be really hard to find people in your area. And so even if people are struggling to figure that out, you can reach out to me and I'm happy to help. I think that that's a huge issue right now. So use me as a resource, even if I can help you find someone in your area. Like I'm happy to help with that if you're struggling.
Thank you. Thank you. I will. I'll drop your email in.
Yeah.
And we will send an email out to everyone with the links that you have shared with us and also the PDFs that you have shared with us and your email. And thank you so
I know
much.
it's a lot.
Thank you so much. Yeah, it is a lot, but it's just all really important. Yep. And Jill, you bring up that bit about nutrition, how important that is for our perinatal families, but particularly I think those postpartum clients, they really need, they get very focused on their prenatal nutrition. And then once they've had the baby, they forget about the importance of nutrition, I find sometimes. So that's a good reminder for us all to keep that. But again, we want to honor people's time and honors Maggie's time. But Maggie, thank you so much. My goodness. Just lots of hearts and hands clapping for you. We really appreciate your time. And for everyone who came today, thank you for coming. We appreciate you guys so much.
Thank you.
Thank you so much. Y'all were amazing. Thank you, everybody.
Thank you. Bye-bye.
Thank you. Bye.
Lots of thank yous in the chat.
Oh, I'm finally getting to look at the chat.
I know. I know. Give you time to look through it too before we close out the session.
Oh.
Such an important topic. I think we all Really appreciate it. Thank you again.
Yes, thank you, Emily. Right. All right. I am going to run to my next client real quick, but thank you so
Yeah,
much,
you
Emily. I
bet.
appreciate it. All right.
We appreciate you. Thank you.
Thank you,
Bye.
Emily. Bye.